Since it's a very broad topic, and I'd like to be precise on the indications and content indications and the results obtained. And since 2021, we've been working with a new version of clinical recommendations issued by the order of the Ministry of Healthcare of the Russian Federation. And according to these recommendations, to treat ischemic stroke, there are only recommendation exists. There couldn't be different recommendations for rehabilitation, stroke, the post-stroke complications. It's all been brought into a single document, and according to this document, the certain things we could go through in more details. For instance, thromboreconstruction. And today, as in 2015, patients with ischemic stroke are not recommended to postpone thromb extractions or waiting for the results of thrombolytic therapy. Why? Because such wait, in absence of recanalization, the functional outcomes could be worse. Additionally, it's no longer recommended in patients after with thromboextraction to postpone thrombolytic therapy. So we have to apply the two methods in parallel. If there are indications for thromboextraction, it is performed. If it's indications for thrombolysis, this method should also be involved. I don't know, maybe in a number of years we're going to change this approach, but the current results for SCIP, I have to say there are a certain number of studies that are currently being published where they re-evaluate our attitude to thrombolysis and thromboextraction, and there are results showing that combination of these methods doesn't give any positive results. So so soon we're gonna have more diverse strategy to follow. Among such studies, there is a SCIP study. It was carried out in Japanese population and didn't give any proofs whether combined reperfusion is better than the thrombolysis. DEFT is another study that showed that these two methods are compared in efficiency. And finally, the 2021 study, Mr. Klein, also demonstrated that thromboextraction is comparable with thromboperfusions in terms of the 90-day outcome. And here you can see that even complete thrombolysis improves clinical outcomes. So today, as practitioners, we can use different combinations of methods to restore brain blood flow. As for anesthesia, there are currently two big meta-analyses that provide two sets of contradictory data, and we are able to perform both sedation and anesthesia. Each practitioner has to decide on their own, and with the for the 6-hour window, nothing has changed much, because we still take patients with some problems with stroke effects in anterior circulation. The 3-6 rule may be not that beautiful, but still correct. And we also can perform thromboextractions in patients with anterior circulation and large ischemic nidus, and we have to keep to account the data that are presented here. This is the meta-analysis of the Hermes register that has demonstrated that in group of aspects to zero thromboextraction gives no advantage in terms of conservative therapy. As for other groups, the results were comparable. And finally, relative to the 6-hour window for the patients with small therapeutic deficiency, you have to make sure that this neurological deficiency can develop the CT or MRI perfusion demonstrated a large penumbra area. So, in average, the threshold has been decreased from 6 to 3 points of the aspect scale. As for the 6-hour window, this slide presents the results of the studies available, and they demonstrate that within 6 hours you can use CT perfusion, and in presence of penumbra of at least 15 milliliters, or the relation of 1.8 ischemic ratio, you can operate a patient beyond the framework of the 6-hour window. And here you can see the results of the down study, where you should pay attention that you shouldn't use perfusion techniques. You can use MR perfusion, which is quite easy and provides the way for widening of indications beyond the 6-hour window based on MRI and maybe even CT data. These are either the fruit of consensus and but no data are available for 24-hour window. And as for patients with a big ischemic nidus, no thromb extraction permission has been given. As for intraoperational stroke, more often than not, if a patient suffers of such a stroke during diagnostics or coronary intervention or aneurysm embolizations in certain medical facilities, those patients are sent to follow the standard stroke pathway, and today's recommendation required the thromb extraction to be performed immediately, and you have to make sure that you do not deal with a hemorrhagic stroke in this case. In case of carotid artery lesions, it is permissible to provide approach to intracranial lesion and remove the hemodynamic stenosis or perform stenting. These recommendations are based on the results of the Titan collaboration, which demonstrated that stenting provides better functional outcomes than in a group without stenting. What is important here that the clinical recommendations now include double degradation therapy to prevent acute stent occlusion, even in presence of thrombolytic therapy, which been widely discussed for many years, and today at the level of clinical recommendation this issue's been resolved, and which is again due to the Titan registry, which demonstrated that the number of complications are not related to thromboobstruction. And the news probably will be angioplastic stenting and anti-aggregates and their combination combination in patients after thrombolytic therapy. As for posterior circulation, nothing has changed in terms of the time window. That's 24 hours. The only available study is the basilar cohort, and based on the results, intravascular intervention turned out to be better than a conservative treatment. Thrombostruction in posterior circulation has proved to be effective according to this study presented here, and I believe that's more than enough to perform this procedure. As for posterior circulation stroke and carotid circulation stroke, intracranial stenting is permitted in case of ineffectiveness of other methods. As for counterindication, I'd like to point out that there are no counterindications for the method listed. So thrombobstruction can be performed in patients with hemorrhages unless it results in the higher risk of bleeding. What does it mean? For instance, you have aneurysmal rupture on the right side, and you cannot perform thrombolysis, and thrombobstruction is not possible according to the previous recommendations. Now it could be done based on individual indication. So if patients suffer of repeated stroke, we can perform thromborectomy no matter how long it takes for the stroke to form. Thrombobstruction can also be performed. And finally, it's not recommended to consider counterindications for in patients who have hemostatic limitations like those indicated on this slide. So where it is not possible to perform thrombolysis, thrombostruction can be performed. So all in all, the recommendations that come into being after being agreed by the authorities and the neurological community, they significantly widen our options and significantly reduce the counterindications, which make it easier for us to select the patients and to reach the gate points. As about the techniques available, you have to use balloon guide because its applications in case of our patients increase the cases of successful recanalization, first past recanalization. And what is interesting here, balloon guide, when you applied it in a combination with the stent retrieval and aspiration catheter, it improves the result irrespectively the technique you are using. These are the newest technique available to us today. This is the stent retrieval in kissing technique for bifurcations of different arteria. These kissing technique allows you to use two stent retrievers for the both branches of the bifurcation, and but if they are put through different vertebral artery, it will be difficult to retrieve them. So they have to be put into through a single vertebral artery, as it's been demonstrated in this study. And as you can see, it enables us to restore circulation in vertebral arteries very effectively. These are the variations of this technique, the so-called crossing one, when stents are put one through other, but it's only possible for certain designs of the stents. And here you can see the results for this technique. and using one stent retriever didn't give any positive effect. As you can see, the crossing technique provided a very good result. And in 2020, we saw appearance of two other technique. That's the stand-in-stand technique and double stand retriever technique. So what's the point? If one stand doesn't work, you put the second stand inside, increasing their radial force, and such approach can work in case of a refractory thrombosis of main vessels. This is one of the example of its application. And as you can see, the stand expansion increases from 14 to 39%, which significantly improves the blood flow. The double stand retriever technique, it's when the two stands go in parallel, increasing the mechanical pressure on the wall of the vessel. So in particular, this technique enables you to increase stand expansion from 48 to 69%, and you can see that it improves the blood flow inside the lumen of the two open stands. Another technique that is available for us since 2021, this is called a tandem stand retriever, and its difference is that first stand is put at a certain distance from the other, so the two stands accompany one another. Adapt is another technique. That's a standard approach, so I'm gonna go over it in details. So it's this technique involves an aspiration catheter and enables the aspiration of the vessel and remove the thrombi. It has a number of modifications, such as auto-adapt, vada-adapt, and adapt-A. When you use modern aspiration catheters, you can put them as deep as the occluded area. There is a large number of combined techniques, and the main technique here is the safe one. It has a number of implications in which the stent retriever should be opened in a way to close the proximal of the thrombosed part of the thrombosed area. Then you deliver the aspiration catheter, and the aspiration catheter go over the stent retriever, so the thrombus is fixed, is caught between the stent retriever and the aspiration catheter, and the aspiration is performed from the guard wire for the whole system to remove the whole system. This is a standard good technique. There's a number of variations, and one of the clinical examples is presented here. The stent retriever is delivered in this area. The whole system has been removed to restore the lumen of the internal carotid artery. The captive technique is a variation of safe. This is an example of the Salumbra technique. Not very good technique if compared to safe, because you can lose pieces of thrombi. Arts is another variations when aspirations catheter is moved to one to another. The Protect technique, which is a modification of the Salumbra technique that involves an occlusion catheter in extracranial part of the carotid artery to stop the blood flow and reduce the likelihood of embolism. And Protect Plus technique, when the stent retriever doesn't go into aspiration catheter and stays outside, which is similar to the safe technique. There also a SAP technique when a stent retriever goes into an aspiration catheter with a proximal balloon to suction the thrombotic masses. So as you can see, the differences are very small, and the only difference are those indicated by their author. So, which technique should you prefer? The Astor study performed in 2018 has demonstrated that no difference been found between two kinds conducted aspiration, which been confirmed by the meta-analysis of more than 9,000 patients. The results are presented here. The Astor 2 study that was published in 2021 demonstrated that the combined reperfusion has no advantage over stent retriever. That's all of the clinical studies so far. So what are our clinical results for to see that we have to check the register, and this is the one named Assist. It was deported by the Stryker company, and its result demonstrate that the survival rate for 90 days for proper outcomes were comparable for the three techniques investigated. And the first past ETK was for the first past ETK was the highest for a combined and aspiration technique. The number of passes was 1.6, 1.8. We can also say that the number of bleedings didn't change much, and a distal embolization occurred in a very small number of cases. But what about our own data? Today we have data for more than 2,000 patients. We've treated for different kinds of collusions of internal carotid artery. So we are talking about anterior circulation. So most the patients were treated with aspiration and combined technique were mainly used in the Janelija Hospital and Burzan Hospital. It's not a St. Petersburg hospital, but it's also participating in our register. Whether it comes to the technical results of the first method, I'd like to pay your attention that aspiration provides the maximum number of possible reperfusion, as the number is smaller for the retriever, and complete reperfusions for combined technique has been the lowest, as for aspiration and perfusion for MTK2B has been lower. So you'd better use a single technique to obtain a good reperfusion. As for low money, the aspiration technique that allows you to reach MTK3 in 70% of cases, and as for safe or combined technique is only 48%. In case of combined reperfusion, you can see that the number of patients with complete reperfusion is twice higher, which is different from the European register we discussed, and it's clear that by the end of intervention, the radicality has increased for every group study and remains maximized for the aspiration group. and a bit lower for retriever group. The good reperfusion was also achieved for the aspiration technique. As it comes to such characteristics at the average number of passes, it was lower for the combination techniques, which means the likelihood of a good outcome after the first pass is better for combined technique, which means it's more appropriate for such patients. As for neurological complications, and hemorrhagical transformation, you can see that the patients with combined reperfusion prevailed, and if we consider a hemorrhagical transplantation, we can see the same for the patients with combined techniques, and their number was higher for the Salumbra technique. Vasospasms, the numbers were about the same, and as for dissections, the results have been better for the Salumbra techniques. As for perforations, in case of retrieving and perforation, that's since no guide wire manipulations are present, the results are as such demonstrated on the slide, and the combined technique is higher, being 19% compared to 6.1% for the aspiration group. As for embolic complications, they've been about the same for every group, but it's the rarest in the retriever group. As for the functional outcome, as the numbers are not inspiring, especially for those who've just started using this technique, and we see the high level of mortality in this group, and in our patients, it's varied from 20 to 25%, and as for good functional outcome upon discharge, you can see the results are better, best for the aspiration group, and the worst for SAFE and Salumbra. It seems that combined reperfusion should only be used only in patients in whom standard methods have proved to be not effective. As for our own patients, their number reached 2011. We've seen the following results. In posterior circulation, in most cases, a thromboaspiration was performed, and a change of technique occurred in the 27 and 6% of cases. As for the technical results, stent retriever has proved effective. Has been demonstrated in the 55% of cases. As for aspiration, that was 74%, and combined technique 66%. So, if in case of occlusion in a posterior circulation, you take a stent, a retriever, that's the blue line, even after 3 passes, you may achieve the same rate of complete or partial reperfusion as in the case of aspiration technique. The same data demonstrated after the 3rd pass. The following passes do not give you any change for better for complete reperfusion. But if you use the aspiration catheter, even after 2 passes, the likelihood of complete aspiration is higher if you work with the retriever alone. So, which means that the retriever, as the method of first choice in posterior circulation, is is a bad choice. You'd better opt for aspiration, and after the third pass, but as for safe technique, it gives you a good reperfusion rate closer to 80%, but you shouldn't use it for more than two passes in posterior circulation because it's not going to improve your radicality. Most likely, we change one tool for another, and their combination has certain peculiarity. If your first method of choice was retriever and you replace it by aspiration, if you haven't obtained a proper reperfusion, you can obtain it with the second instrument only in the 33% of cases. If you've taken aspiration catheter first and you replace it by a state retriever, the total increase of radicality is not going to increase 33%. And if for aspiration you went to safe and it cost as much as the aspiration alone, 54% of your patients are going to reach complete reperfusion and 36 going to reach the 2B reperfusion. So it's the best option. You start with aspiration and follow with safe. Is the diameter of the patient's arteria low? And if none of that is possible, you perform balloon angioplasty or balloon angioplasty with stating in 80% of cases you may obtain positive results, but there are a risk of dissection and anterior intersclerosis. So all in all, aspiration is the first technique has resulted in MTK 2B and MTK 2-3. And unfortunately, in posterior circulation, not everything can be determined by successful retraction. So in the posterior circulation, successful reperfusion depends on the technique you've chosen, using a stent retriever in more than 4 passes and the aspiration catheter in more than 2 passes. You have to change the technique if you're not satisfied with the results. And the aspiration is the optimal first technique, and you'd better opt for safe or stent retriever if nothing works. And if nothing works, even then you have to perform angioplasty to resolve the issue. So let me stop you